Thank you, Pedro. So I'm going to show my worst complication of orbital atherectomy, and I'm going to show two cases, both illustrating really the same thing that I'm going to show in the cases as to how we can avoid complications like this. So 76-year-old male, sort of worsening chest discomfort and shortness of breath on exertion, hypertension, hyperlipidemia. And in previous angiogram had mild right coronary disease and mild LAD disease. So there's the medications. EKG showed some very subtle key waves and inferior hypokinesis on echo. So these are his angiograms. So you can see cranial pictures. You can see vessels are calcified, but tortuous, but nothing really. The circumflex looks small. So there's a reason for that, and you'll see next case, next slide, actually. So that's your right now. So 50% went to 99%, and now you have all these filling defects and calcium. So big right, supplying pretty much the whole circumflex territory also. So patient is symptomatic, so it's calcium, and you'll see another view here, angulated, looks like eccentric, nodular, and superficial calcium. So obviously, these are the kind of lesions that are difficult to wire, number one, and first of all, second of all, probably difficult to cross with any balloon, and even if you cross, most likely won't really yield. So we actually wired with a microcatheter. There's another picture on the right. So wired with a microcatheter and changed it to a Viper wire. And then we're able to perform orbital atherectomy. So, you can ask me after all these cases that we've seen is why did we do orbital? Why didn't we do rotational? You look at the wire bias and all those kind of things. I'll show you. I think it doesn't make that much of a difference. I think technique is important, but I think there are scenarios where I think these devices really don't do what you really want them to do. So if you look now, this is after our orbital atherectomy. Looks pretty decent, right? He said, well, we know we crossed it. We did everything good. It looks pretty good. There's a little roughed up in the middle, but I think we have created a channel, so we feel pretty good about this. And then we said, okay, we're going to balloon it. So balloon expanded nicely all throughout. Looks good. Looks good. So we IVUSed it. And you see, why I show you in this picture here, you see the mouse going? No. So if you see that OCT image, you see with the way the wire is sitting, if it's an eccentric calcium, if you see that angle of it's greater than 90 when the catheter is touching area which doesn't even have calcium, and the guide wire is touching that area also, that's classic bias on OCT. And if you have that, even if orbital atherectomy is supposed to bounce off, they say, it hits the hard tissue, it bounces off the soft tissue. It's wrong. What it does, when you have this much bias, what it does, it actually dissects your intima and your media and pulls it off. And the only thing you see is adventitia. And so you may or may not fracture the calcium on the other side. So that's your stent. Looks pretty good, huh? We feel pretty happy. Everything expanded. We did orbital. Very nice.
But with your, evaluation, yeah, we see what happened. But with your evaluation, you anticipated this?
No, this is what happened.
Oh, we saw it in the previous picture. Yeah.
Yeah, previous picture. So this is after stent. It didn't happen with orbital and stuff. And this is what happened is we actually gutted and removed that intima and media of the adventitia. So when the stent expanded, it had nothing to expand into, and it expanded into the path of least resistance and perforated it after the stent. So now, at this time, patient is not doing well. You can see it's as bad as the classification of perforation gets, and patient is not doing well, so obviously.
Jess, we didn't see that on IVUS, did we?
No.
We didn't see everything removed, I mean, the three
No, we saw
walls.
it, we saw it. I'll show you a picture of it.
Okay.
Yeah, we saw it, absolutely. We saw it on IVUS, actually, and we look back, you saw it on IVUS that actually moved it. And what happens with orbital is when you do orbital, and if it crosses the lesion, okay, you have to be very careful, especially in tortuosis. When you're cutting backwards, you have to be very slow. Don't get excited. You go in there and I'm gonna pull it back. And that's what happened. When you pull back, it actually knots it. And then when you take a next pass, you feel like a rubber band. But your lesion is crossed already. So you take a next pass, you feel a rubber bending phenomenon. That is when it gutters it. So that's the only time you'll get perforation. So if you feel that, don't push it. So we were doing this and we actually made a mistake and we pushed it because we wanted to make sure we were able to deliver the stent. And that's exactly what happened. So you can see the pericardial synthesis drain. We, put a papyrus stent obviously in there and we sealed it.
Usually several papyruses, right?
Was that?
Usually it's more than one.
No, I'll show you. So we put 2 papyrus stents in there. We sealed it. Patient is hemodynamically stable. Left the drain in. Sent him to CCU. And you'll see here, this was our post-IVUS after papyrus. I'm not going to go over this, but I'll show you. It looked like we sealed it. Everything looked good. And then patient was admitted to CCU. Then developed significant hypertension. I went to see the patient. As soon as we saw the patient, I called the surgeon. I said, listen, I think this is leaking. There's pericardial clot and stuff on the echo. I said, we have to take him to surgery. As soon as we took him near the elevator, started coding. So we were coding the patient, went to surgery. Actually, the surgeon was very, very quick and very good. He had found multiple tracks of bleeding around the papyrus stent. They had to repair with a patch and glue. And patient did well and was discharged 8 days later. And our patient actually last week saw the primary cardiologist and has having some discomfort and inferior ischemia, so they're going to get a CT angiogram. So I'm going to figure out what's happened. I wish we had CT that I could show you, but this is another one, and I'm going to show Dr. LaSala's case here real quick also, which is illustrate the same examples. This is a case that he did that had a mid-right, pretty simple. You say, well, maybe shockwave it, but it's eccentric calcium, so we decided to do atherectomy, and you'll see nothing happened after atherectomy. Stent, and then this is what happens. This
Wait
is
for it.
exactly what the bias it looks like. So this is what atherectomy does. So the key is very important to understand that these things happen, and the reason it happens after the stent is for obviously that nodule and path of least resistance. So when you are doing backward and forward, the technique has to be very, very important. So, this patient obviously did okay, and then what happens is, I'll show you, sealed it, then the patient 1 week later had problem again, and you can see what happened. You see that pseudoaneurysm that forms in the stent?
And you notice the patient's an atrial fib too now. 'Cause
Yeah, I see the fib.
The blood in the pericardium is a very potent irritant.
Yes.
Look at that.
So you know what happened? They put another one. So here, I want to illustrate the fact. So it says differential sending, reduce plaque while potentially minimizing damage to the layer. Don't believe that, okay? The technique is important. If you have a bias and if you have that OCT finding that shows you the contact of the catheter with the guide wire bias, you have to be very, very careful with the technique. Otherwise, you're going to have both these cases. Because of bias, you're going to have perforation. Also, orbital atherectomy, do not do high speed. High speed with wire bias and tortuosity results in perforation. Okay, that's the only perforations we get is from high speed because of the bias I showed you. Don't go 120, you do not need 120. CSI, Abbott needs to take away that thing from 120. Just make it 80, make it simple for people. It's very, very important. So, these are the complications of orbital atherectomy. You guys are familiar with perforation is the most common one. We had a live case from England, actually. They actually broke off the orbital bow. Crown, and it went down into because it was so tortuous, and they were pushing too much, it broke it off. So this is what I was saying. So frequency of orbital injury, if you look at it here, if you're OCT, catheter, or even IVUS, if you see the guide wire contact, And if you see that angle of where the catheter sits in the path of least resistance, that's where you have the most injury. 90-degree angle greater than end guide wire contact, you have a largest amount of orbital injury and resulting in perforation. So, and I'm going to show you one thing real quick here. Papyrus is not 100%, okay? When you do both our cases, you had late leaks. So when you do papyrus stents, you got to observe the patients very, very closely. One had pseudoaneurysm because it's a single layer thin, right? As opposed to graft master, which is stent sandwich.
Right.
One, stainless steel, and this is cobalt chromium and only one layer. So that's why it fractures, and I'll show you why in our case. Here, let me go back here. Look at this. So this is papyrus stent with a leak from the calcium nodule that there, it breaks the thing and it starts leaking behind.
Beautiful case.
So thank you guys.
What a fantastic explanation.